Well, good afternoon or good morning, depending on where you are. We appreciate you for joining us today, and we'll get started in just a moment. We want to give everyone a chance to get logged in. So grab your lunch or your water. I've got mine here with me, and we'll get started in just 1 minute. Thank you again. I hope you've enjoyed that great music to get us set and started for the day. So come on in, whether you're on Facebook Live or YouTube, everybody get settled. And we have an exciting treat for you. Well, my clock shows 12:31 and we want to be mindful of your time. Hello again, and thank you all so much for taking time out of your busy day to join us for today's Lunch and Learn entitled The Power of Prevention, a Dementia Update, presented by the Southern Area of the Links Incorporated. On behalf of our amazing Southern Area Director, Mrs. Vanessa Falls, and our Southern Area Program Coordinator, Dr. Prasharon Dixon, I want to take this opportunity to welcome you all today. I'm Dr. Tedra Anderson Brown, and I serve as the chair of our Southern Area Mental Health Initiative, and I'll be moderating today's discussion. Here in the Southern area, mental health and brain health are two of our intentional focus areas. And we remain committed to our theme, Links Power, prioritizing our well being and embracing resilience. Because we believe that knowledge is indeed power, and we know, unfortunately, that dementias of all types disproportionately affect our people or people of color. So today, we want to take a moment to particularly discuss vascular dementia, the ways that we can prevent or decrease the impact on people of color, particularly in terms of dementia, and become advocates for our cognitive well being for ourselves, our loved ones, and our communities. We know that today's discussion will be both enlightening and empowering for all of us. Now, I have the pleasure of introducing you to our esteemed guest speakers, Dr. Melissa Burrows and Dr. Isaiah Roll, who are joining me on the virtual stage. Dr. Burrows is a non-invasive cardiology at Wellstar Center for Cardiovascular Care with a clinical emphasis on heart failure and hypertrophic cardiomyopathy. Dr. Burrows also has expertise in global health and health and equity. She serves on the board of directors of the Association of Black Cardiologists and has conducted research throughout the United States, Puerto Rico, and beyond. She's also co authored over 23 scientific publications. She is an associate director for the American Heart Journal and also currently serves on the steering committee for three ongoing clinical trials. Dr. Burrows was born in St. Louis and raised in Atlanta, Georgia, right here in the southern area. She graduated summa cum laude with her Bachelor of Science degree from Emory University and cum laude from Harvard Medical School. She trained in internal medicine at the University of California, San Francisco, and completed her cardiovascular training at Duke University, where she also received her master's in global health. She is a member of the Dogwood City, Georgia chapter of the Links Incorporated and serves as our Southern Area's Health and Human Services Committee and our National Heart Links co-chair. She has a passion for mentorship and has mentored college students, medical residents, cardiology fellows in both clinical research and medicine. She is committed to promoting innovation in healthcare. Welcome, Dr. Burrows. And
Thank you.
you're welcome. And I also have the pleasure of introducing you to Dr. Isaiah Roll, who is a native of Harlem, New York, the first African American to earn a neuroscience PhD from the University of Cincinnati and a first generation physician and scientist. He is a doctor of osteopathic medicine and completed his neurology residency at Emory University, also here in the southern area, where he served as chief neurology resident. Dr. Roll finished his training with a fellowship in vascular neurology and currently works as a stroke neurologist at Grady Memorial Hospital and a neurohospitalist at multiple Emory community hospitals. He is actively engaged as well in student mentorship and bedside teaching. He is an assistant professor of neurology and serves as the associate program director of the neurology residency program, where he is dedicated to fostering the growth of future generations of socially conscious physicians. He believes patient education to be essential to the effective patient care and often posts social media content on neurology topics and frequently conducts community health talks like this one on health education and disease prevention in local churches and community centers. Dr. Roll considers his most valued commitment to be his wife and family and is a super girl dad to his three daughters. Please put your virtual hands together and welcome Dr. Burrows and Dr. Roll. Well, I'm excited. We're going to start with you, Dr. Burrows. You take it away and share with us a little bit about the connection between heart health and brain health.
Well, thank you for the introduction. I appreciate it. So, I want to walk you through a diagram where we talk about the framework through which we understand cardiovascular disease, which is my area of expertise, and then cognitive dysfunction, under which dementia is what we're focusing on today. And as we see, they share many of the same risk factors and some of the underlying disease processes. So many of the patients I take care of have had a history of high blood pressure, coronary disease, heart attacks, but oftentimes they've had strokes. And what I explain to people is the same disease process, which is atherosclerosis, which you can see under cardiac disease, vascular disease in which you have inflammation and cholesterol lining the arteries. When it affects the heart, it causes a heart attack, but when it affects the brain, it causes a stroke. Not every neurologic injury is as dramatic as a stroke. Oftentimes, people have this sudden decrease of movement in an arm or a leg, a speech disturbance, or some dramatic change which alerts them to the stroke. But what many people don't understand is that some of the neurologic injury is more subtle and sometimes more chronic. And it can often occur at the microvascular level, meaning it's the small blood vessels. And when that happens, that's often when we start to see a subtle decline in cognitive function, and that can present as vascular dementia. Now, when we move over to the left side of the diagram, it's really the risk factors that I want to focus on this afternoon. And particularly in African Americans, high blood pressure is the number one risk factor, often driving disproportionate outcomes, both in vascular dementia, but also in cardiovascular disease, including heart failure. And high blood pressure is often called the silent killer because most patients do not have any symptoms. In fact, it's not uncommon for someone to not know that they've had uncontrolled high blood pressure until decades later they have an event such as a stroke, a heart attack, or heart failure. And that's not the time that we want to find out about our high blood pressure. We want to find out about it early enough to intervene to avoid the bad outcomes. Now, when people do have symptoms, sometimes it's not clear that it's blood pressure. It can be a headache. Some people will think that they have migraines, and in fact, it's blood pressure related. The headaches from high blood pressure sometimes are more noticeable in the morning, but they can occur at any time. Blurry vision sometimes is a cause of is a result of the high blood pressure, and then sometimes chest discomfort and shortness of breath. But like I said, for most people, they don't have symptoms. And so you don't want to wait until it's that bad before you seek medical attention. That is probably one of the main reasons why regular checkups with a primary care doctor is so important, because it is to screen for these things like high blood pressure, which often don't have symptoms. Now, one question that I get is, well, what is a normal blood pressure? And I want to spend a little time on this just so that everyone can understand what is the goal and why we're so aggressive. In the past, 140 over 90 was considered kind of the threshold for high blood pressure, and the 130s over 85 was considered borderline. However, we updated our guidelines with brain health in mind. And it was because we realized with more data and more clinical trials that the stroke risk was further reduced if your threshold for high blood pressure was much lower. So, with the updated guidelines, which really aren't that new, they're probably almost 10 years old, we know now that it's more ideal to have a blood pressure in the 1 teens, and a blood pressure of 120 over 80 is actually considered borderline hypertension, and it's not normal anymore. And when we're treating patients, we do take into account their age and their fall risk. But if we want to optimize the reduction of stroke, we want to take them below the 130s. And so that's really important because, especially for young people, if they are on medicine for high blood pressure and they've gotten to the 130s, I let them know that the job is not done. That, if you are 35, 40 years old, I do not wish that you live another 40 years with a blood pressure in the 130s. If we want to improve our brain outcomes, reduce stroke risk, and reduce some of the things like vascular dementia, we want to have better control on the blood pressure. The other thing that I want to highlight are other risk factors, including cholesterol and diabetes. Diabetes can affect the blood vessels as well, both the large blood vessels, which we say macrovascular effects, and the microvascular effects. And that also can play a role into your brain health. Diabetes is treated often with medicines to lower blood sugar, but we have newer agents that get to some of the underlying metabolic issues that cause diabetes. And it's often important that you kind of take that into account when you're getting advice from your doctor. Specifically, medicines like the GLP-1 receptor agonists, medicines like Ozempic is the trade name, it's semaglutide is the generic, or Mounjaro is the trade name, tirzepatide is the generic. Those medicines kind of get at more of the underlying issues and thus will have more downstream benefits, including weight loss, effects on the kidneys, liver, and heart health. So we want to remember that the brain is a part of the body. And what's good for the body is good for the brain. And oftentimes we're looking at the whole person rather than just isolating organ systems. The other thing that I want to take into account is cholesterol. As we mentioned, atherosclerosis, which is vascular disease, is in part caused by elevated cholesterol. It's not the whole picture. Inflammation also plays a role, but lowering cholesterol is an effective intervention for stroke reduction and to improve cognitive outcomes. And then the last thing I want to talk about is weight and lifestyle. Because as a cardiologist, we don't want to just focus on giving people medicines to improve blood pressure, cholesterol, and diabetes. We want to look at the whole body to optimize health. So things like diet, exercise, and sleep are really important. Sleep is considered one of the components of ideal cardiovascular health. We are appreciating it more scientifically and incorporating it to our guidelines. And what we recommend is regular sleep and at least 7 to 8 hours, and that you go to bed roughly the same time every night and you wake up roughly the same time every night. It has many metabolic benefits, which can explain many of the cardiovascular benefits, um, and including reduction of stroke and heart attack. Exercise is important independent of weight loss. Exercise has many vascular benefits, including at the microvascular and the large vessel as well. And then the diet. And I emphasize that people try their best to minimize the processed food in their diet, particularly the fast foods, the processed foods, the snack foods. Those foods tend to have a lot of salt, sugar, and fat, which is pro inflammatory and can often promote some of the underlying disorders that can cause vascular dementia. Now, we will have a nice discussion coming, so I know that there'll be more questions that we will answer. And for now, I'd like to pass it over to my colleague, Dr. Roll.
All right, all right. Thank you so much, Dr. Burrows. I'm excited to be here to partner with Links and to talk also alongside Dr. Burrows. And I want to kind of get right into it. Our topic today is prevention of dementia, and so I'm talking here about dementia. Dementia is our umbrella term. It's a large word that encompasses a person who's having difficulty with their memory, their cognitive function that's impacting your daily living. And so this dementia is the word, but there are many different types underneath this umbrella, as you'll see. And so the first one we'll talk about is Alzheimer's. That's one that's most common, or some of you all call it old timers. Alzheimer's is the most common type, but after that comes vascular dementia. Okay. And next after that is the mix of the two. You may have a mix of vascular and Alzheimer's, and then so on and so forth down the line. But in my world as a stroke neurologist, vascular dementia is actually the most important type of dementia. Why? Well, any version of having vascular dementia is going to make you more likely to have other issues and going to make the course worse for someone who may have Alzheimer's. Their symptoms may be more severe by having vascular as a part of it. And so in my world, vascular is the most important dementia. I want to add some data here. I looked at some studies just recently, and it showed that Black women over 65 years old are at a really high risk of dementia. And that's the highest of any social or racial group that we found in this country. But they experience very distinct inequities in obtaining a timely diagnosis and a timely treatment. Not only that, but there's the highest amount of chronic discrimination, which actually causes brain damage, and institutional discrimination in the form of healthcare or what have you among Black women. And finally, women in general are the most common caregivers. When I'm in the hospital seeing a patient, if there's an older patient, more than likely it's going to be a daughter or a niece who's in there taking care of this person. And so taking care of persons with dementia is going to be really challenging. It's very complex, and it's due to a couple of factors, things like cost, lack of awareness of resources, as well as the stigma associated with seeking help. And so we're going to talk today about vascular dementia, but before we get into dementia, we can't do that without talking about stroke. And so we'll go to the next slide. And so I'm going to give you all the three most common causes of stroke. As a stroke neurologist, this is one of my favorite topics. And so the first one is large blood vessel disease. Okay, these are when you have blockages of blood flow. All right, and so you have blood flow that goes from your neck to your brain. When you have blockage of that blood flow getting to the brain, that causes a stroke. And so these largest blood vessels can get packed with these cholesterol plaques Dr. Burrows mentioned. And so the cholesterol, when you get your labs done at the hospital, at your primary care office, you get your cholesterol numbers. The part of that cholesterol that's most important for me today is the LDL. That's the bad cholesterol. That drives the production of this cholesterol plaques in those vessels and can lead to those kind of blockages that we see that can cause stroke. And so I want to get your cholesterol numbers checked, but also pay attention to that LDL and get that number much lower. The second type of cause of stroke is small blood vessel disease. The most common reason why we have these small blood vessel disease is going to be high blood pressure. And so small blood vessel disease is when we have changes in the smallest blood vessels due to issues over time. And so if you have long-standing, uncontrolled high blood pressure, the pressure on those vessels are so severe that it causes small changes and small damage over time, and those vessels are damaged and they can cause strokes. Unfortunately, we don't always have symptoms of even these type of strokes. And so when you hear someone talk about having a silent stroke or a mini stroke, more than likely it's because they've had damage to these small blood vessels. Now, I'm not from the South originally, but when I moved to Atlanta, I saw a certain pattern. You know, when you're in healthcare, you see a patient who has a certain name and demographics, and usually has their medical history. Well, I would start seeing patients that had a numerous amount of medical history in the same patient. It would be high blood pressure, diabetes, chronic kidney disease. It would be high cholesterol, CAD, obesity, smoking, and it was all be in one patient. And I named this the Deep South Special. And so the patients who have this Deep South Special are the ones that are most commonly having the small blood vessel disease type of stroke. And then the final one is number 3 is cardiac or cardiac clots, heart conditions. The most common thing that we see is AFib or atrial fibrillation. So normally your heart beat right on time, right on rhythm, like that record that's playing. But in AFib, it's erratic. You have some fast beats, you have some slow beats, it pauses for a moment, and it gives time to have a blood clot form and then go up from the neck into the brain and cause a stroke. And so these are most common 3 types of stroke, which are important, or 3 causes of stroke, which are important into how we get to vascular dementia. Okay, next slide. And so vascular dementia is our topic for today. Vascular dementia, what is that exactly? Well, vascular dementia. Vascular is just blood flow to the brain, and the dementia is having an issue in your, or difficulty in your cognitive domains, major areas, things like communication, things like learning new information or communicating. These are, when you put them together, you have vascular, you have dementia. And so it's caused by long-term blood flow or poor blood flow to the brain over time, typically caused by a series of strokes. And so I want to give you some symptoms that are commonly a part of vascular dementia, which are pretty distinct from Alzheimer's dementia. And so the first one is that's abrupt onset. I mean, stroke happens like the stroke of midnight. And so these changes go from day to day. And so you were doing fine today, but then tomorrow you woke up, you had a major change to your ability to function. That's that abrupt onset. The second part is the stepwise decline. That means that you're kind of coasting, doing well here. You had a major change that brought you down. You never kind of got back to where you were in the previous few weeks. And now you're coasting normal. And you have another stepwise decline again. And so like a staircase, you kind of have stepwise decline. That tends to be the pattern, which is different than Alzheimer's, which has a very slow, kind of more smooth sort of decline, whereas vascular has a more sharp, abrupt onset declines down and down. The gait can be off. That means your walking can be off, not because you don't have the strength to move your legs, but sometimes that brain processing that tells you how to coordinate your steps can be difficult, specifically in vascular dementia. Motor impairment. This is your movement itself. And so you're weak on one leg or one arm. That goes hand in hand with having a stroke, as well as having these cognitive changes, is your motor impairment part of it. Urinary incontinence. This is a really big one. Now, it's a very complicated one. I mean, some people have this issue for a myriad of other reasons. And so if you don't have these other reasons for having urinary incontinence, but all of a sudden you have this major change where now you're having difficulty with your continence, that may be one of the issues and symptoms that we see that go hand in hand with vascular dementia. Emotional lability. So if your emotions are labile, now I mean, this is a change. This is not what you used to be. You're kind of crying in areas that don't really make sense, or you're laughing inappropriately at a TV show that really isn't funny. Your emotions just can't be regulated very well. That's another factor. And the final one is mood changes. Now, we don't want to talk about this, but mood. I'm talking about someone who's not already known to have mood issues, right? If you're already kind of grumpy to begin with, it may be kind of hard to tell, but for someone who's not known to be very moody, now having a lot of irritability, that fuse is much shorter than it used to be, those kind of mood changes. So these are things that we see that are a little more specific to vascular dementia than they are with Alzheimer's. So we're going to move on and give you a little bit more symptoms of vascular dementia. The next slide. And so if you look online, you may look up and you may find the 4 A's of dementia. You may find the 5 A's of dementia. You may even find the sixth age of dementia. And so I decided to put them all together, and the 456 A's of dementia, and I give you an extra one, a lucky number 7 from my days of paying CeeLo in Harlem. And so I want you to kind of follow with me and see if we can learn together. And so the first one is aphasia. Aphasia is difficulty with language. You want to say the word apple, but what comes out is actually car or chair. This doesn't make sense. You can speak, or maybe perhaps even your language production has just gone down. And so you're not even able to produce as much language as you used to be. That's aphasia. Number 2 is apraxia. That's difficulty with purposeful movement. And so if I ask someone to stimulate what it looks like to comb their hair, but instead they sort of do a motion that's almost as if they were going to brush their teeth, that's difficulty with purposeful movement. Number 3 is anomia. That's difficulty with naming objects. And so again, you can see the object, you're looking at it, but you just can't put the name to that object specifically. That's anomia. And then similarly, there's one called agnosia. This is difficulty with recognition or recognizing objects. And so you see it, you may even kind of have an idea about what it might be called, but you really can't recognize it or what it's used for. Amnesia. This is an easy one. Amnesia is difficulty with remembering events. Number 6, we have apathy. And so this is difficulty with showing interest. And so if you were the person that loved to go fishing, every Sunday at the church, and that was like your entire hobby, that was your life, you love fishing all the time, but all of a sudden the same person just has no interest. They're like, just don't want to do it. That would be strange for them, wouldn't it be? Well, that's what's called apathy. And then finally, I'll give you the last one, the big word that I even have trouble pronouncing, is anosognosia. This is difficulty having awareness of your condition. You don't realize how sick you actually are. Perhaps you're weak on your right arm, you can't move it, but you think you have the full strength, right? And so you can see how much this can be an issue, and that someone doesn't even have the recognition of their symptoms or how sick they really are. And so these are the 456 A's of dementia, and we're going to kind of move on to the next slide here. So I want to give you all a little sample of what I look at every day. My favorite thing is MRIs of the brain itself. And so if you look at the very top here at C, this is an MRI of someone's brain. They're 77 years old. They've taken a mini mental status exam, and so their cognition is great. They have no issues at all. And they have this mild white matter changes. Now, the white matter disease or changes are changes that we see on an MRI of the brain, which really represent the damage to those small blood vessels, all right? And sometimes the large ones. So again, that deep south special, those small vessel changes show up as white matter changes on an MRI. And so this person at the top in C has some white matter disease. It's not very much, but they're doing pretty well at 77 years old. And for them, that's pretty normal. If you go to the bottom of the screen, this is a patient who has dementia, and they have severe white matter changes. They're 81 years old. They've not done too well in their cognitive testing. And you can see how much more white spots there is on that brain than the one above, right? That's pretty dramatic. If I did a brain scan of someone who has Alzheimer's disease, I would not expect to see any of these white matter changes at all. And so if I have a patient who has some cognitive issues, some memory concerns, some language issues, and I do this brain scan and I see the white matter changes, I'm much more likely to diagnose them with vascular dementia than I am with Alzheimer's disease. And if you look over to the left of your screen, I call this the silent epidemic, because this is a lot of white matter disease, and they don't always cause symptoms. And so I'll do an MRI brain scan of a patient, and I'll tell them, hey, you've had a stroke. And they say, I've never had a stroke before. And I say, well, your brain scan is telling me otherwise. And so it's a silent epidemic because you have these small blood vessel changes from that deep south special that are causing changes, and it's pounding on these small issues, causing damage over time. And it's not until it coalesces into a much larger area that someone actually has symptoms. And so the fact that we can see these changes in someone's brain lets me know the overall health of your brain throughout the years. Okay. So next slide. We're going to move into some risk factors. And so the dementia risk factors, I found this online from Alzheimer's Disease International. They have 12 risk factors, and I'm going to read them for you really quickly. First is physical inactivity. 2 is smoking, excessive alcohol, bad air pollution, a head injury, infrequent social contact, less education, obesity, hypertension, diabetes, depression, and hearing impairment. Now, when I became a neurologist, I learned an old adage we used to say. It was called diagnose and adios. That meant that neurologists for many years have been really great at just looking at a patient with their eyes, scanning them, doing an exam, and figuring out with a high degree of certainty exactly where your problem was. But the other hand, the other issue with that is that we didn't have much treatments to offer them. And so we would diagnose and then we say adios. That's changed in recent years. The last 10, 15, 20 years, there's a plethora, a big explosion of treatments, but there's also a big focus now more on prevention. And so if you look at this list of 12 risk factors, think for a moment, how many of these risk factors are modifiable? How many of them would you be able to kind of work on to kind of reduce someone's overall risk of stroke and dementia? You can look at it pretty quickly. And so I can only find one here. That's a head injury. If that happened, you got hit with a baseball bat when you're 12 years old. That's something that happened in the past. But 11 out of these 12 are all things that can be individually worked on to reduce and to kind of reduce someone's stroke and dementia risk factors. And so I think it's pretty encouraging to me that we can work on ways to treat all of these things and reduce our overall risk of having dementia, having stroke, and the vascular dementia for someone who's not had any of these risk factors. I'm willing to bet they're not going to have those white matter changes. But if you've had these things for many years, especially those that are untreated, the likelihood of you having those white matter changes and likelihood of moving towards vascular dementia becomes pretty high. Okay, so I'll leave you with some final thoughts in the next slide. In the conclusion, which is really just to get intimate with your risk factors, right? It's never too late. You kind of start at the beginning, right? Get tested. We have a lot of our testing to kind of figure out your cognitive domains, but also, as Dr. Burrows mentioned, the blood pressure, your diabetes, the high cholesterol numbers, those are the things that you kind of start with. And I encourage you to share them with an accountability partner, which your numbers are right now, and then start right this way. For my caregivers, I want to just kind of make a mention to take care of yourselves. That's the most important thing you can do for yourself, is take care of yourself as well, because the burnout of being a caregiver for someone who has dementia is really, really difficult. And so I want you to feel empowered with the necessary resources and social support to balance the stress and responsibility of caring for those loved ones who have dementia. So thanks for your time. I'll leave you with that and get it back over to Dr. Tedra. Thank you all.
Wow, just amazing presentations. Thank you so much to both Dr. Burrows and Dr. Rowe for making it plain. I love the end with the call to action. I'm just in awe and I have so many questions. It's probably my favorite part because I call it a chat and chew, where we get to really have a conversation and dive a little deeper into that call to action, because I think both you and Dr. Burrows alluded to it. So we want to kind of really answer some of the questions that I know you get. And also, we had some of our committee members who submitted some questions as well. So first up for you, Dr. Burrows, you mentioned, what's good for the body and the heart is good for the brain. And it seems like the opposite, right, is also true. What's bad for the heart and the body is bad for the brain. And in that context, can you share a little bit more with us about this association between high blood pressure or hypertension, and we heard about the vascular dementia piece for stroke, and what can and should we really be doing about it? Like in reality, like what could I do today or tomorrow or next week to prevent or lessen that risk?
Well, that's a really good question. And what Dr. Roll showed was very powerful. But he also didn't mention that in those radiology reports, normally they say microvascular injury from high blood pressure. Like they put it in the report because that
Mhm.
is the underlying disease causing mechanism. And so what do we do to prevent this? First is, know your numbers, because as I said, most people won't have symptoms. So it's too late to wait until you have symptoms. Once you have neurologic injury from uncontrolled high blood pressure, I can't reverse that. The best I can do is keep you where you're at. But if you've already gotten so bad, we can't make that better. So prevention is essential, especially when it comes to dementia and neurovascular injury. I think the other thing is to focus on lifestyle. So if you don't have high blood pressure, do everything you can to prevent it. As people get older, their blood pressure tends to rise. So it is kind of an uphill battle at each decade to prevent high blood pressure, especially if you have a family history. And many of us, including myself, have family histories of high blood pressure. So we
Mhm.
know it can happen. And that is really, kind of the discipline of diet and exercise. And I like to refer it as a discipline because it really is the little things you do every day. So exercising at a heart healthy walk once a year is not going to move the needle. You'd be better off doing 5 minutes a day than doing 2 hours once a month. And I think the data support that as well. Same thing with the diet. It's the little dietary habits that start to sneak up. I was talking to someone today about sugar. The sugar habit is real and it is addictive. It's not you, it's the sugar. And so getting in that habit of having a little bit of candy at work, and sometimes work is the problem, um, it adds up. It adds up. And so I encourage people to think about those small things, those snacks while they're eating, while they're watching their favorite TV shows. Sometimes just eliminating that and they can drop 10 pounds. And
Mhm.
so, that's the kind of things that we focus on in prevention.
Awesome. Thank you so much. And you mentioned something that I want to just highlight, the intentionality, right? Doing over and over. And I know you all are very familiar, and some of our audience may have heard recently about the Pointer study. It's been on Good Morning America, it's been in the New York Times about the benefits of lifestyle changes to decrease those risks of heart disease and brain disease. So, Dr. Burrows, can you share your thoughts about any additional things that we should be doing? Like, should we be asking our doctors for statins? Should we be asking them for GLP-1s? Like, how do we get the treatment in addition to the lifestyle changes? Because sometimes there seems to be a little disconnect there.
That's a good point. I mean, in the modern era, we have interventions, we have drugs that are very effective. Starting with the statins. Statins are cholesterol lowering medicines. They've been around for over 30 years, highly effective at reducing heart attack risk and stroke risk, and have a safety profile that is better than most of the things that I give people on a daily basis. Statins have gotten a bad rep in the literature when it comes to dementia, and it's important to talk about that. Every day, a couple times a week, I hear, will taking a statin increase my risk of dementia? And the literature looked at this very rigorously with several meta-analyses to see. And what we find is what we call confounding by indication, meaning that the people who are at risk for dementia are the same people who need statins for other things, like they're high, for coronary disease and high cholesterol. And so when you look at the data with rigor, there is no causative effect. If anything, there will be a benefit because of the vascular benefit of the statins. Now, the GLP-1 receptor agonists are really important because I mentioned there's underlying metabolic derangements that are actually driving a lot of these diseases that we see. And we're understanding that the fat secretes substances that are harmful to your health. So it's not just the extra weight you're carrying, it's actually causing direct impact on the microvasculature, the small blood vessels, in addition to the ways in which the body metabolizes sugar and glucose. And so that's what has been so effective about the GLP-1 receptor agonist, because with the changes from taking those drugs, then you start to see less of those harmful effects of the visceral fat, which is very pro-inflammatory. It can cause fluid retention and microvascular dysfunction. And so I do encourage people to ask their doctors, because over time, doctors are becoming more and more comfortable prescribing it. And if your doctor is not, then they will find someone who is. But you'll be surprised that your primary care doctor might have been thinking about it, but just was afraid that you weren't open to it. And as soon as you mention it, their eyes might light up. And cost can be the biggest thing, so we have to take that into account. But all things being equal, it's a highly effective intervention.
Okay, thank you so much for that. And Dr. Roll, I want to just pivot for a moment, because one of the things that I know you get asked often is, how do we get our loved ones to go and get the evaluations that you mentioned? Sometimes, they don't think something's wrong, right? And they don't want to talk about the symptoms. They say, "Oh, I don't need to go see a doctor." What thoughts can you share for our audience about how to encourage their loved ones to go get checked out?
Yeah, absolutely. I would say, first of all, I understand, just being around for a little while, that a lot of people don't want to go to the doctor in general. But I think oftentimes they just haven't found someone they probably feel comfortable with, and it may take a little bit of shopping around. To be quite frank with you, um, they I have patients open up to me very, very, very easily when they finally feel that they're in a space that they can be able to share. And so sometimes I think it's a matter of just finding that the next person, and it's the people are not going to take any offense to it. You just got to find the right doctor. But I would say, specifically for cognitive concerns, I tend to try to frame it to people that, we just want to just get a baseline to see how you are right now.
Yeah.
That way, if something should change 5 or 10 years from now, we can see where you were, and that'll give us a good chance to see, okay, is there any changes? And so, I think people often don't want to go because they may sense that they're sort of being sentenced to a diagnosis and they don't want that to be told to them. But I think if they're going with the idea this is just a baseline, let's just see how you're doing. It's very very non-threatening, and they need to be shown exactly what it looks like. Most times it's just sitting down, you do a little bit of reading some words, you're drawing some puzzles, putting it together. So it's a very non-threatening thing, but we have to show people what it looks like so they can kind of say,
Yes.
oh, that's sure. I'll do that. That's not a big deal, and you can just take the information and leave with that. And so I'd say those kind of just giving people more information about what exactly is happening with a cognitive test or an assessment. Just not trying to diagnose them, not trying to put them in a box, and also finding someone they can feel comfortable with to be able to share those things, because most people probably have a little bit of internal worry and they just don't want that to come out. And so avoiding it is just a better plan for many people than really acknowledging
Hmm.
even some of their own worries about their own memory issues as well. Last thing I'd say is, I think the more we can try to create a social support around each other will be helpful. I find many patients don't want to get diagnosed. It's not because they don't want to take care of themselves, but they just don't want to be seen as a burden to the rest of their family around them. And so they'd rather just, I mean, it may not make sense to everyone, but they just may not want to go that route because they don't want to be, oh, now I
Yeah.
have this, now I have that, and you got to take care of me. Especially my older Black men. They're just like, look, now, leave me alone. So I think just giving support to know that, look, we're all going to do this together, no matter what the outcome might be, may kind of help in that way.
That's great advice. And as a psychiatrist, I have to say, I love that approach, right? Non-threatening, but also you mentioned like the cultural sensitivity. So this is why we're so excited to have both of you here, so that folks can see and hear from folks like us. And so I'm going to just ask you, Dr. Burrows, again, another question, because you mentioned, and we've heard this several times about, the diet piece, the weight management piece. How can we tell a good heart healthy diet from like an unhealthy fad? Because I know, at my age, there's something that I have back and forth gone with, and some things I'm like, this, I feel worse. What can you tell us about that? We hear a lot about Mediterranean diets and all kinds of things. So, what is your recommendation for the heart and the brain as far as diet?
Now, the diet is definitely the top question I get most days of the week. And, I like to remind people that all weight loss diets are not necessarily healthy. So, yes, you can lose weight eating bacon and eggs 3 times a day, but it will raise your cholesterol and worsen your cardiovascular outcomes. So, we don't recommend that. The benefit does not outweigh the risk. And so, a lot of times we're focusing on a version of the Mediterranean diet. Mediterranean diet refers to an eating pattern that existed in Italy in the 1950s. This is kind of post World War II era. And at that time, they were eating a lot of plant-based food, minimally processed food, whole grains, fruit, vegetables, lean protein with chicken and fish, and then the healthy fats, the healthy oils, the olive oils. What's not included, which I have to say, well, what's omitted? Dairy. So this goes contrary to what many of us were taught in school, and is controversial. But dairy is not necessarily part of the Mediterranean diet. So eating a high dairy diet sometimes will drive up cholesterol and create problems for people. What's also not included is a lot of sugar and butter. So a lot of things that people are eating that's processed, and just a lot of processed food. I think what I like to tell people is I lived in South America for a year, and I loved the food there. I lived in Lima, Peru. But South Americans, when they come to the States, what they notice about our grocery stores is that we have more aisles in the middle of the store. And when you go to a high-end grocery store in South America, the shelves don't have as much food because there's not as much processed food. All the food requires refrigeration and it's on the edges. And when you look at people's shopping baskets, they've got big bags of potatoes and peppers and, plants that look like something that came out of the ground. And that's the kind of eating that we need to get back to. And when, since we are in the southern area and we're talking about a southern way of eating, I try to tell my patients in the South to think back to how their great grandparents and their grandparents ate. My grandfather's from Mobile, Alabama. He grew his own beets and okra and tomatoes. He was not eating fried chicken and macaroni and cheese every day. We were eating gumbo and beets and a lot of healthy foods and beans. And if you can go back to those beans, not only are they cheaper in the current crisis where people cannot afford a lot of food, but they're healthier. And so that is the positive Southern eating pattern, because I don't want people to think the South is all bad. There's a lot of good things here and a lot of things that we need to remember from our heritage. We didn't inherit
Yes.
this came about from processed food that really was popularized after World War II. So we got to go back to the 1930s when you're eating okra and beets. But that is that is kind of what, and this resonates with all types of Southerners of all colors. Some of my clinics are kind of in the fringe of Metro Atlanta, where people do eat more of a rural kind of traditional pattern, and talking about the beans kind of alive and something in them. So they stop thinking about the fried food and the processed food as much.
Yeah. Thank you so much. That's great. And I know, just for our audience to know, we got word that you may have to drop. I want to just remind everyone, these are real clinicians who are saving lives. So we appreciate that you could join us. And I'm going to just, Dr. Rowland, just say thank you, and we'll be in touch. So Dr. Roll, I love that when what Dr. Burrows is saying about, get back to what our ancestors are doing, because they had it right? Eat healthy foods that you grow out of the ground, and then be outside, like exercise, get it in, right? Be with your people. And one of the things that was really interesting you talked about, and this is National Family Caregiver Awareness Month, was that stress of isolation and the stress of caregiving. Can you say a little bit about some ways that we can kind of use movement and exercise to even decrease that stress and decrease our risk?
Yeah, absolutely. So I would start by saying I for sure promote exercise a lot. And I know we hear that everywhere. It's like, yeah, obviously diet and exercise, right? But I say it specifically because in the time that I spent doing research, I did neuroscience research, and the topic that I spent years doing research in the laboratory, like pipettes and science things, was really on a part of the brain that's responsible for our learning and memory. And the part of our brain that's responsible for learning and memory, we have brand new brain cells that are born every single day. It's one of the only parts of the brain where you actually have brand new cells born every day. The rest of your brain, what you start with, you get, that's all you got. But there's a few spots, and this is one of those areas. Well, the ways that we found in our research that you can stimulate more brain cells being grown is by exercise. And so exercise stimulates what's called neurogenesis. And so you can actually build brand new brain cells by exercising. I think that's wonderful. I think it's impactful. I can preach that up into the heavens every church I go to, because it's not just like I'm exercising my muscles down here, but I'm exercising for my heart. I'm also exercising for my brain itself. And so I think from a risk factor standpoint, exercise will give you brand new brain cells, gives the opportunity to heal even some of those damaged areas that have already been done over time. To moving on to that, to the caregiving side of it, exercise is a great way of relieving stress in general. I read recently about stress, especially chronic stress over time, and we've found in the last 10 years that actual daily stressors, like you get cut off when Atlanta's 85 and someone curses you out, and it's like the things just stacking, and your boss calls you a name, and it's like by the time the day is done, you're like, if I don't just but that chronic stress over days and months and years, it's not like the one stressor today is going to raise your blood pressure. It's that chronic stress over time actually causes cellular level brain damage. And so again, the exercise is a fantastic way of reducing that stress in the moment, reducing that stress over a couple of months, and reducing your overall risk of stress, by itself. We'll share some resources later, I think, with you all, but I think from a caregiving standpoint, exercise and using your resources to find some time away for yourself, respite care, having someone be able to kind of spend a few hours with your loved one for you. I know it's not easy to trust other people, but when you find a person who can give you a few minutes to walk away, go to the gym, go outside, take a walk and exercise, and get some time to yourself to help decompress will make you a lot better caregiver for your loved one, and a lot less stress for yourself as well.
That's great advice. And I want to say I'm smiling because I don't like exercise, but what I realize is I don't have to be a marathon runner, right? I just need to do something several times a week, get my heart rate up, and not be sitting on the couch channel
Yeah.
surfing, right? I can't exercise my fingers and not exercise my body. So I think that's what was helpful for me. My doctor, primary care doctor, explained it because I kept saying, I don't like it. She's like, just get outside. And again, that's another thing our ancestors did, right? They got outside, they talked with their neighbors, they, were in the garden. So let's get back to that. I think I have time for one more question. And one of the things I wanted to ask is if you've already been diagnosed or someone, your loved one, has already been diagnosed with a dementia or even mild, what we call MCI, mild cognitive impairment. What are some things you recommend that person or their family do? Like if you had to like kind of sum it up in a couple sentences, what can we do if you're already at that point to
Right.
prevent it getting worse?
Yeah, absolutely. So a couple things I'd say. First, I would ensure that you have been seen by a neurologist that specializes in cognitive health
Mhm.
specifically. A lot of people are just handed out diagnoses, by the way. Just kind of they hear some story, they're like, "Yeah, you probably got dementia," right? And that's not appropriate. So I would make sure you're seeing a neurologist, see a cognitive neurologist, so you can get the appropriate testing. I say that first because there are many what's called dementia mimics. There are a lot of things that can happen in your body metabolically, in your mind, that can mimic dementia. And one of the examples, for instance, is unaddressed or untreated depression.
Yes.
Depression is a great, great, great mimic for dementia. I mean, you're so depressed, you don't know where you put your keys at, you forgot how to get to work, your memory's all off. And so someone's like, "Yeah, you probably got dementia." Maybe not. Maybe you've just been depressed for quite some time. It hasn't really been addressed quite well. So seeing a specialist will really help to ensure that we ruled out all of these very easily treatable and reversible causes of acute memory loss or chronic memory loss. That's step one. Number two, if you have been diagnosed, I would say that the risk factor management is still just as important as it was if you haven't been diagnosed, because
Hmm.
some folks have what's called mild cognitive impairment. They have a little bit of issues, but they're still able to get throughout their day, and they're lack of a better term, they're coasting for 10, 15 years and they're doing quite well. They've got a little memory issues. And so sometimes the symptoms or how severe that someone goes through a certain thing like dementia can be a lot milder when those risk factors are being well controlled and being well addressed. And so some folks, get into a full blown dementia, and it's like the white matter changes are so severe that they kind of really get somewhere very far very quickly, as opposed to someone else with better control of those risk factors. They may have a much easier course, and they're, for lack of better terms, able to be independent for a lot longer.
Hmm. Hmm.
Finally, I'd say that um, making your life a little more like less cluttered and a little bit more organized and planned will help you out. And so what I mean by that is if your home is complicated, if things are everywhere all over the place, you don't know where stuff is, you want to declutter your home and you want to kind of put yourself on a normal schedule. That way you can kind of know where things are. It's going to be in a consistent place. You're going to have something at a consistent time. And that way your brain has very simple cues to get through the day. If your life is so complicated, it's going to be a lot more to manage and a lot more to forget and a lot more to kind of have issues with. But if you kind of declutter and kind of give yourself some very, very normal and simple routines, it's easier for the brain to manage simple, consistent routines and not kind of really mess up and throw you off, versus having a very complex life. And so those routines, those reminders, I know many of us don't want to get into it, but we are in an age of technology. You can grab that little Alexa speaker and tell Alexa, look, remind me at 9 and 3 and 6 take my medications, and it'll
Yes.
so we want to use them to our advantage to kind of help simplify your life around the difficulties you may be having.
Oh, that's awesome. I mean, so amazing. Our time is just about coming to a close, Dr. Roll, but can you share where our audience can find you on social media? Because I know you're very active on social media, and we want them to be able to follow you and see all of the great information that you have to offer.
Yeah, yeah, well, absolutely, sure. I post primarily some videos that are on neurology topics and patient care topics on Instagram, and so I'm Dr. Isaiah Roll, and so you can just find me just at Dr. Isaiah Roll on
Okay.
Instagram, on YouTube, on Facebook as well, and I try to post some of those topics just to kind of help people have something that they can kind of take home and have with themselves to kind of remember, because a lot of information at one time, and you're in a doctor's office, what have you. I don't see patients in the clinic because I'm in the hospital 100% of the time. So I'm an emergency stroke neurologist. So I'm in the hospital all the time. But I do post those videos on social media from time to time.
Well,
Mhm.
we appreciate that and appreciate you sharing it. And we
Yeah.
do have some resources that one of our sisters is going to drop in the chat where you are. To those who are in our audience, if you are in the Atlanta area, one of them is Empowerline
Mhm.
org, which is amazing. I actually looked at it, I was like, oh, wow.
Mhm.
And if you're impacted by what's happening right now, they actually have resources where you can go and get food and other things that you may need. Obviously, ARP, which is one of our national partners for the Links Incorporated and the Alzheimer's Association. So we're going to drop those in the chat for you. And there's also the Family Caregiver Alliance at www.caregiver.org. So we want to make sure that you all have access to all of those. I have learned so much today, and I'm a physician, but we want to keep learning, and we have the power to change this narrative about dementia in ourselves, in our families, and in our communities. Before we go, though, we wanted to share another learning opportunity with our audience because, as you know, and I mentioned earlier, November is National Alzheimer's, Dementia, and Family Caregiver Awareness Month. The southern area of the Links Incorporated, our national trends and services facets and our arts facets are collaborating with AARP to bring an event called Caregiving, which is going to be broadcasting live on tomorrow. You see it on your screen at 8 p.m. And so we hope you would join them. It is executive produced by Bradley Cooper and narrated by Uzo Aduba. So we want to make sure that you are aware that here's another opportunity, particularly for caregivers, to have another line of support. And on behalf of our Southern Area Director, Mrs. Vanessa Falls, our Southern Area Program Coordinator, Dr. Persharon Dixon, and the entire Southern Area Mental Health Initiative Committee, thank you all so much for joining us. We really take this seriously, and we look forward to continuing this important work in our local communities with each of you, with our Southern Area chapters, all 83 of them, and with our community partners. We pray that you will have a wonderful rest of your day and make it a great week. Thank you so much for joining us.